Going to try and discuss a little bit of the research we've done in the last year, largely done by one of our fellows, and really kind of hinging off of one of Chris Howe's study when he was here, going from there. So here's my disclosures. Again, nothing really relevant. So starting again with the case, this is a 70-year-old female. She has cardiomyopathy and a pacemaker. She's seen by medicine, thought to be a reasonable candidate for surgery as she has developed progressive truncal imbalance, pain, claudication, and really feels that she's lost all quality of life. So she's assessed by medicine, assessed by anesthesia, felt to be a reasonable surgical candidate. She undergoes this T9 to sacrum procedure, as you see here. You can see that she has good sagittal correction, good lumbar lordosis built in, 4-level T-plifts, multiple osteotomies, and this done in a single stage, takes on the order of 8 to 10 hours, 2 to 3 liters of blood loss. But she's looking pretty good. Post-operatively, she goes to the ICU for a night, mobilizes on the floor, and then suddenly on day 4, she's found apneic and pulseless 4 days afterwards and is dead. So how can this have been avoided? Where does all this play out? So as you kind of follow up on this case, which anybody who's done a lot of deformities probably has some similar type case, you then kind of backtrack and say, should you have done this case at all? Was this indicated? Was this a patient that was too complicated? Were we missing some sort of consult with respect to this? Should this or could this have been a stage procedure, and would that have changed the ultimate outcome on this patient? Would it have made a difference? What was the real cause of the patient's death? And we worry about all these complications that we know can happen in these patients. Death, MI, stroke, PE, blindness, paralysis, to mention kind of the top ones, not to mention all the other things that can also happen with these patients. And then, of course, these complications have major impact. They can have a major impact on the patient. If they have a stroke or MI, they may never fully recover from this. Can have a major impact on the patient's family and their loved ones. Death, if they lose their loved one. If the patient has a stroke or something, they may be in a nursing home for the rest of their lives. So these can have a major effect. And then, of course, us as surgeons, we hate to be selfish, but there's a major psychological impact. There's a major time impact as you're trying to go see these patients on a daily basis. Maybe they go to your rehab facility, and you're seeing them every day for a month or something. They can be very complicated. And then, of course, underneath it all, unfortunately, there's the medical legal repercussions, or could there be? Did you do something wrong? Was something overlooked? Despite you doing everything appropriately, is this going to come back and drag you through the mud of a medical legal case that ultimately you may win? But again, that's no good either. So on that sobering case, if we look at the demographics of deformity and scoliosis, we know that this can occur in both the degenerative population as well as kind of a residual or worsened idiopathic. We know it increases with age, as has been demonstrated in Schwab's article. We know it's higher in women than in men, and we know the associated symptoms, low back pain, sciatica, neurogenic claudication, are common complaints that these patients have. Traditionally, these patients were all treated conservatively. We didn't really have good tools with fixation limitations, complications. However, we also know that from numerous studies that we can improve on these patients' quality of life, their walking ability, their pain, their deformity, their decreased need for analgesics. And anybody who's taken care of these are some of your happiest patients that will come back, barring complications, assuming everything turns out okay. So the complications, as we know, again, are potentially devastating. These have been looked at in numerous studies. MI, stroke, blindness. There's long surgeries. They're expensive, lengthy hospitalizations. We know from our own study here that Chris Howe did a couple years ago and was just published in Spine in 2011, a 45% rate of complications. Depending on how you define these can be as high as 80%, as described in the Leatherman Institute's publication that came out in 2003. So what we did is, looking through the literature, we know that there is a certain amount of data, though limited, looking at the staging of procedures. And it's obviously very easy if you're doing a stage anterior, posterior, anterior. It's very easy. They're kind of very separate procedures, and maybe it can be done separately, and there is some data on that. If we look at posterior staging, the only article of any substantial weight that's out there is this article by Rhee out of St. Louis in 2003. It's really kind of a retrospective study. There's no control group. It's 42 patients. Some of these are actually staged anterior procedures. And interestingly, they say staging is a reasonable alternative, and they had no major complications in their study as they defined major complications to be. But this is really the only study looking at staging of posterior-only procedures. So hinging off of the study we had done here previously, looking at 103 patients, we had a 45% major complication rate, 5% mortality rate at a year, with no variables found to be associated with this. And complications were found to be associated with ASA, estimated blood loss, comorbidity, not with age. And again, some of the other sobering statistics, 17% return, 17% rate of infection, 35% return to the OR. So this data was humbling. We decided to take the next phase of the study to see, can we in any way decrease these things or change the ultimate outcome with that? And with that in mind, we've kind of, over the last year, taken our investigation to the next level, trying to look at a comparison of stage procedures versus non-stage. So all of these are done posteriorly. This is not an anterior, posterior, anything like that. This is a staging where typically our definition of staging for most of these patients is go in, do the exposure, put in all the instrumentation, close up, and a week later come back and do osteotomies, T-plifts, decompression, put in the rods, and that's the second stage. So we wanted to compare these, looking primarily at perioperative complications at 90 days to see if there's a difference in outcome. Our hypothesis on our study was that staged posterior correction of adult scoliosis results in fewer major complications when compared to reconstructions performed in one setting. That was our hypothesis. So retrospective review, all of these patients had at least a thoracic to sacrum or ilium fusion. A single surgeon, this was Dr. Chapman's patients, 2000 to 2010, looking at both the University of Washington and Harborview. So we tried to take out as many factors as possible, and we thought if we kept it down to one surgeon, we could at least take away any variables that may otherwise be involved in this. We looked at our methods. We had 142 patients. Of these 142, 52 fell into the stage group, 90 fell into the non-stage group. So again, a bit of a difference in balance here. This was a retrospective study, and again, trying to parcel this out. We looked at the invasiveness index as has been described previously by Mike Lee, as described by Mirza in Spine 2008. We looked at blood loss, intraoperative transfusion, and these various other factors. I think something that will come up later and we'll discuss in more detail, we looked at both an intent to treat and as treated analysis was done. And what this is some of these patients that were meant to be unstaged ended up being staged. And so we tried to parcel that out to see what factors led to that failure of treatment, I guess. So I think this is really kind of, the next few slides will be kind of the meat of what we found. If we look at this and break this down, we can see that, again, 52 in the planned stage, 90 in the non-planned. If we look at age, slightly different. Is that a factor? Maybe it is. Again, a shortcoming of a retrospective study. Sex differential, ASA not different. If we looked at the invasiveness index, we did find that it was very slightly higher in the planned stage group than in the non-stage group. Again, this was found to be statistically significantly different. Does this really matter? Don't really know. Part of our theory retroactively was that probably in a stage procedure you may be willing to do more than you would do if you're trying to rush to the end point in a non-stage procedure. Estimated blood loss was higher, transfusion rate was higher, ICU days was higher in the planned stage group. So these things would make it look like it's a negative impact. Again, our real focus here was on complications. If we look at our complications here, we can see the breakdown here in the planned stage and the non-staged. Looking at the ones that we think are the most significant, blindness, infection, death, MI, stroke, PE, pulmonary issues, really no statistically significant difference if we look at this purely from a statistical standpoint. I think that that's a key thing is, we talk about the parachutes and does that need to be proven? What's the difference between a death of 4 versus a death of 1? And would you change your practice if you knew that your death would drop by half, even if it's not too statistical? I think these are some of the deeper level of reasoning that play into this and maybe are unanswerable questions. If we look again, as we talked about the intent to treat, we had out of these 79 patients, 11 fell into this unplanned stage group. So these are ones that were planned to be all completed in one phase, but did not quite make it there. And when we looked at these separately, we found that 12.2% of the patients, 10 were due to coagulopathy, 1 to unresponsive hypotension, and anesthesia basically said, close up shop, you can't finish this, you got to move on. When we looked at these, there was a high ASA level in these 11 patients. There was a higher total blood loss in these 11 patients as well. And those are really the only factors that were found to be different in the preoperative phase. If we look at the statistics and now parcel out, again, we have our stage and non-stage, then we have our unplanned stage. We can see that there was a slight difference here in our ASA, suggesting that these patients were maybe a little bit sicker. As you can see here, a higher blood loss. Is that due to the staging? As we know already that stage procedures have a higher blood loss than the non-stage. There did appear to be some sort of coagulopathy involvement in these patients as well. Again, looking at our complications, really no statistically significant difference. Again, trying to parcel out primarily with this, as we saw in the previous slide, trying to see if there's a difference between the non-stage and the unplanned stage. Really no substantial difference that we could really come out of this. So as we look at our as-treated analysis, the comorbidities were not correlated with complications. Stagings and complications were not correlated. Our estimated blood loss was higher in the staged versus non-staged. Our transfusion was higher in the staged versus non-staged. Our ICU days were higher in the staged versus non-staged. And higher ASA factor was the only factor contributing to the need for unplanned stage surgery. So I think, again, none of these are probably big surprises looking at blood loss, transfusion, ICU days, given the stage nature of these procedures. We then break this down into significant differences. Really no significant differences in complications if we look at this purely statistically, and again kind of listing out the previously mentioned things of blood loss and transfusion. So our conclusion was from this was that estimated blood loss, transfusion rates, and ICU stay are higher in the stage surgeries. That's kind of expected. We did not find any significant differences in perioperative complications in the stage and non-stage groups. But again, I think we have to weigh that all out, and does it really matter? Does it have to be statistically different to really make a difference? Both stage and non-stage procedures may be reasonable approaches for adult scoliosis. Now, surgeons should be aware and responsive intraoperatively. A lot of these patients developed a stage procedure unplanned, so it's important to be in communication with your anesthesia colleagues, recognize, keep updates with your blood loss, your blood pressure, coagulopathy, various things like that. Patients with a higher ASA, a higher likely spine invasiveness index, and higher estimated blood loss should be considered for staging was kind of one of the take-homes from this, and that's kind of more on the scientific side. I think that what we have done, partly as a result of what we anticipated ahead of time, we didn't really prove our hypothesis, but basically what our protocol now is for most of these that we plan to stage almost all of the thoracic to pelvis deformity cases, except for the very simplest cases. And again, although there's no statistical difference, we found that it somehow, our perception is still that patients seem to do a little bit better and it's a little bit safer. So our usual protocol again is do the exposure, do the instrument, do the screws, call it quits, get a CT scan in between there, make sure that our instrumentation is accurate, and then come back on stage 2, revise any screw that is not as accurately placed as is ideal, do the decompression, do osteotomies, T-pliffs, whatever else needs to be done, and put in our rods, and that's kind of our current protocol. Again, unscientific, but that's kind of what we're doing to try and improve our safety profile. Thank you.
Okay, Bob McGuire is going to follow now with his lecture on geriatric patients, the coming crisis.
Thanks, Carlo. Let's kind of get back to to our standard, our orthopedic tree. We've got a tree here, we've got a stick in the ground, we've got some ropes that kind of hold it up on this thing. And what do we really do? We look at that tree, that's basically our bone structure. Okay, the screws are that, and the plate and the rod are the things that we can use to stabilize that. The interesting thing is what happens to that tree as we get a little bit older. Well, all of the materials that are there to help us form bone are still there. As we get older, we've got all of that matrix, those proteins, those osteoinductive areas, so they're still working. But I want you to look at the tree. What happens to the tree? Here we are kind of at the area when we start. Look at those rings. Those rings are pretty good size. What happens now as that tree gets older, they get a little bit thinner, right? Well, I kind of look at this as a toilet paper theory. All right, the longer that roll stays on that in the bathroom there and you're kind of using it, what happens? It starts getting thinner and thinner and thinner. So you wind up, when we start out, we look pretty good. Our bone's pretty thick. We got a nice solid roll that's there. As we get a little bit older, we thin that roll out significantly, and it's kind of interesting that it's important to know that we reach our peak of bone basically in that 30 to 35 year age. How many of us are at 30 and 35 years right now? A lot of us are on the other side of that, so we're already on a bad side of the fence. Not going to be a whole lot that we can do to keep our bone mass present on this. This happens to be my timeline. So I'm kind of looking at my toilet roll is going to get pretty thin in the next 10 years or so. So I'm going to have to do something to try to minimize the risk of my structure falling apart. Again, what happens when we get older? We lose those internal stabilizers for that bone. We lose that cancellous component. Those fibers become a little bit, those structures become a little bit thinner, becomes a little bit easier to crack. Now this is where the real key comes in. How many folks are here baby boomers? I see a lot of them out there. Yeah, absolutely. Every 7.5 seconds, a baby boomer turns 50. There's a lot of us in this room, so if you remember any of these things, you fall into that baby boomer category, okay? So here's a real problem. It's osteoporosis and osteopenia. Ladies and gentlemen, we're at epidemic proportions right now. It's not just in the U.S. This is going to be a global problem that we have, and we're going to be basically discussing the hips and the spines today. We've got about 78 million baby boomers that are there. So we've got a gray tsunami that's getting ready to kind of come ashore, and we've seen in the recent past what a tsunami can do when it hits. It's a terrible situation. Looking at the world population, basically we're going to have a 47% growth of these baby boomers that are there. 8.9 billion by the year 2050. Median age is going to be between 26 and 50 years of age, and there's going to be a huge number of people that are over 80 years of old. Now you remember that graph that I showed earlier, and we'll show it at the end, the use of medical care as we get older incrementally increases. So we've got a real problem. Problem is these folks are kind of mobile. They're at much higher risk of injury. So we're going to have to develop some type of method to treat them because we have not been able to prevent it because, again, they're already over that 35-year group. So what we're about to see is a group of folks that are tremendously educated. They've got a lot of free time, and they're basically going to resculpt the industry. Part of that industry is us fixing things. Part of that industry is pharma, looking at materials that we can use to try to stabilize those bone structures, things of that nature. But we've got a real potential problem with us. And when you look at this, our vertebra, our hips, and our wrist are going to be the areas when people fall, that's usually what they break. Now let's just kind of look at this. This is going to be the oldest boomers that are there. We kind of keep falling along this category. And then as the next 5 to 45 years, look what happens to the curve. The curve tremendously shifts to the right, and there we are in our fracture level. So this is going to be a huge problem when we start looking at fractures of hip, spine, and in the wrist area. We talked a little bit about the general conditioning, the medical comorbidities in the discussion this morning. The classification of our fractures, especially in the wrist and the hip areas, are going to become very critical because we can't treat a 26-year-old who was involved in a car wreck the same as we would treat a 78-year-old involved in a car wreck. The instrumentation is just not going to work because of the bone quality. The bone quality is a situation that's going to really dictate what we can and what we can't do from our instrumentation. We know the risk factors, the female Caucasian, increased age, estrogen deficiency, family history of this problem, smoking history, love to drink the carbonated beverages. We know that they're at a huge risk factor of developing this. And when you start looking at the fracture patterns, when you see these comminuted areas, huge problems as far as the fixation. Okay, so what can we utilize to be able to assess this? We know that our fracture management, in looking through these processes, that there are certain things that will work and certain things that won't. When we've got normal bone, we can use the standard plating techniques that we have. We don't have to lock that stuff. They work fine. Osteopenia, we want to use kind of a mix of the lock and unlock. Osteoporosis, these folks, you're going to have to lock them, okay? And then the severe osteoporosis, we're going to have to use some type of composite, and this is basically what we're seeing. We all know these potential categories to fix this thing. And then one of the things that we've really not developed well is the bone glue. We've got all this methyl methacrylate, all these different cements that have a tendency to give us stability, but they don't go away. And that's one of the problems that we'd like to be able to solve, and that we are working on, is an appropriate type of bone glue. Composite fixations are things that you have to utilize to assist that internal structure of that bone to be able to stabilize in conjunction with your fixation. We are starting to look at some alternatives in our hip fractures as far as looking at materials that we can inject into these areas of fracture to help stabilize our internal fixation. The nice thing about the hip is that the same techniques that you can develop for stabilizing hip fractures, you can then slip over to the bone. So if we can develop something that will give us fixation of our instrumentation within the hip, it'll work very well within the vertebra itself. So when you look at hip fractures, and let's just kind of look at this. These are the folks, we're talking about a T-score minus 2.5. Probability of a hip fracture of an individual greater than 50 years of age. A white female is 14%, males are 6%, black female 6%, 3% in the male. Interesting thing is when you look at the morbidity is if you have a fracture, you have a 1 in 5% or 1 in 5 patients are basically dead at 1 year post-injury. So there's tremendous morbidity involved in this, and that only 30% of these folks that have this fracture get back to their pre-fracture status. As far as the U.S., we're not unique. This is global. When you look at the estimate of worldwide fractures, in 1990, 1.66 million. Look what it's going to be by 2050, 6.25. So now all of a sudden this increased number, not just in the U.S., but also globally, is going to be a huge problem. So we're talking about cost, incrementally, tremendous cost involved as we have this particular problem. So what are our fixation alternatives? If we look at barnacles, I don't know if anybody's got a boat that they've tried to clean, but you can't get the barnacles off the bottom of this thing. So I think what we need to look at is that sticky stuff that's holding the barnacles on because they live in a nice saltwater environment. They have a strong bond. Even if they're dead, it's hard to get off. And they're compatible with the physiology of things. So those are the kind of materials that we're going to be looking at, and we are looking at, to be able to stabilize things. What about the spine? Aging is inevitable. If we're fortunate enough to kind of hang around, the spine's going to age just like the rest of the bone. 700,000 fractures each year. You have 30% of these folks will go to a chronic pain situation after they have one of these fractures. So they're going to be banging on Alex's door to be able to try to gain some type of relief on this. 85% of them are due to primary osteoporosis. If you look at again, the mortality for these spine fractures, the age-adjusted increase in mortality from an individual that has a spine fracture is 15%. So they're not innocuous problems on these things. One fracture, you have a 5-fold increase of having another one. If you have a female with a low bone mass, a huge increase in the propensity to have a vertebral body fracture. And again, as we said with the hips, you have a spine fracture, you've got a 30% increase in the mortality, just like it is in a fracture. They're not innocuous problems. So how do we treat them? Well, we got bed rest, we got these hospitalizations, we got the narcotics, we got the bracing and the surgery. How well do they do? Well, bed rest certainly doesn't help. The longer you stay in the bed, your bone continues to go away. Problems with inactivity, again, the narcotic problems that we have. Bracing also doesn't work. They don't fit well. The patients won't wear them. The skin doesn't work right. The progressive kyphosis, what happens with that as you continue to bend forward? The abdominal contents have a tendency to kind of go up into the chest, start developing pulmonary problems, huge problems along with the balance and the gait, and then the chronic pain component. Again, patients hurt, they kind of can't do the things that they want to do, they wind up and they get depressed. And Alex, you're exactly right. Nobody wants to talk about this aspect of it, but the folks that come in with these particular problems are all depressed in my practice. I don't know how it is with everybody else. So surgery, we talked about that. Trying to do one of these spines, the multi-level degenerative scoliosis, you might as well just not even consider it because the hardware, you've got to be able to put something in reasonable bone for it to stay. In these individuals, it just doesn't work. Well, what about the vertebroplasty and the kyphoplasty? This is the thing that everybody is jumping on. This is also a lot of the things that I got jumped on when we did the guidelines because the literature is just not out there that really supports this type of procedure. So what are we recommending? When you look at using the vertebroplasty and the kyphoplasty, when you look at the level 1 data, it doesn't support it at all. There is some support for an acute fracture of using calcitonin, usually within the first 4 weeks of the fracture. But those individuals that have a fracture that have been treated conservatively and then still have a continued pain, there are actually studies that support, so weak support of the use of kyphoplasty after the fact to give some improvement on that. So again, as a guideline state, We need to individually address all of these patients. We can't just knee-jerk them into one category and think that we're going to be successful in our treatment on this. The slides here, tremendous interest in this because it does affect the mortality of these patients when you have a hip and a spine fracture. So it is not an innocuous type thing. You've seen this one before. The older we get, the more that we utilize, and again, the specialty where we're falling in, we're going to be the ones that are going to be using most of the money. So I think when we start looking at the baby boomers, they're going to be here, they're going to be active, they're going to be injured, and we've got to figure out some way better than what we have right now to be able to fix them. This happens to be one of the ladies that just kind of retired, bought her a nice new motorcycle, and you can see exactly what happened within about 2 days of this motorcycle. Unfortunately, we were able to kind of put it back together. But I think what we're going to have to do is kind of come back to that tree. We've got to figure out not only now with our youngsters being able to prevent this particular problem, but also what can we do to prevent these fractures. And I think basically every chance that we get, we need to educate these people. We need to make sure that they're getting appropriate calcium and vitamin D. Weight-bearing exercise is what you want to do. You want to stress that bone. You want to be able to kind of have Wolff's Law kind of come into play. Consider the use of the hormone replacement the therapy. And I am a Tai Chi guy. I like to use these balance type things to kind of keep folks from falling. I think of the older folks, it's very important to get them involved in some type of these activities like this. Again, the consideration of the bisphosphonates and calcitonin for the bone mass. We have a very active rheumatology group at our university who deal exclusively with this. And then I think Forteo, or the Pulse PTH, is certainly something in the future that we really need to be looking at to be able to get these folks' bone stock up to a reasonable quality on this thing. So I think what we can do, everybody's wanting to make everything green. I think what we want to be able to do is use these particular principles and make sure that we've got everybody's tree that's strong enough to be able to kind of support them for the rest of the life on this thing. Thank you very much. Appreciate it.